Hello and welcome back to GI 101. My name is Dr. Adriana Lazarescu, and I'm a gastroenterologist at the University of Alberta in Edmonton. This podcast series is intended to discuss common clinical problems arising from the GI tract. With me in the GI 101 studios today is my co-host, Dr. Dan Sadowski. Dan, what have you brought to discuss today?
Well, Adriana, this week I would like to discuss the case of a young man with intractable nausea and vomiting.
Sounds intriguing.
So this was a 41-year-old male who was referred to me for assessment of recurrent episodes of vomiting and dehydration over the past 2 years. The interesting thing was that each episode was the same. The nausea would begin suddenly and rapidly progress to significant vomiting, to the point of dehydration even. He has required multiple emergency department assessments, and frequently he has been given IV fluid therapy for rehydration. On average, he has one of these attacks every 2 weeks.
How is he between episodes?
Well, another interesting thing is that in between episodes, he has been completely well. He has no daily symptomatology, and his appetite and weight are stable. I should also mention that his past medical and surgical history are unremarkable, apart from a smoking history of 10 cigarettes per day. Specifically, he has no history of migraine headaches.
Has he had any investigations for this problem?
During his visits to the emergency department, he has had multiple investigations. His lab work has been essentially normal, apart from a slightly elevated serum creatinine, which indicates significant dehydration. Other labs, white count, serum lipase, and liver enzymes are normal. Plain films of the abdomen have been done on multiple occasions and have showed no evidence for bowel obstruction. CT scan of the abdomen was normal. Gastroscopy previously done was normal. CT scan of the brain was also normal.
Anything to find on physical exam?
When I examined this young man, he was healthy, muscular, and there were no stigmata of micronutrient deficiency or chronic liver disease. The abdominal exam was completely benign on exam. In particular, there was no evidence for a succussion splash. However, when I examined his upper torso, I saw an unusual reticulated rash on the posterior aspect of his flank and buttocks, pictured in this slide here. As I have not seen anything quite like this before, I asked him about this rash. He stated that this was the result of scalds that he had received while laying for long periods of time in a tub of hot water. He soaks in hot water frequently to obtain relief whenever he has one of his acute vomiting attacks. His wife, who was also present for the office visit, stated that he often spends 4 hours or more in the tub using large amounts of water and often drains the entire hot water tank.
Well, that is a very interesting clinical story. I wonder if this is a good opportunity to discuss the clinical approach to nausea and vomiting.
Sure, why don't we do that? In my experience, there are 4 different clinical patterns by which nausea and vomiting present. These are important to identify as each one has a slightly different differential diagnosis. First, patients may present with chronic nausea with no vomiting. Second, patients may present with an acute vomiting syndrome of 24 hours or less, often with significant clinical dehydration. Thirdly, patients may present with vomiting without nausea, and this can be due to regurgitation or rumination. And lastly, patients can present with chronic self-limited episodes of nausea and vomiting, but in between episodes, the patient is quite asymptomatic. For our listeners today, as you gain more clinical experience, you should be able to recognize which of these syndromes your patient has. Because nausea and vomiting are such common clinical problems, it would be a useful exercise for you to build a concise differential diagnosis for each one of these syndromes and keep it handy for future reference.
It definitely sounds like our patient today has the 4th one, chronic episodic nausea and vomiting.
I would agree, and the value in identifying this clinical presentation is that there is a very specific differential diagnosis for the causes of episodic nausea and vomiting. This differential diagnosis includes gastrointestinal problems that produce intermittent obstruction, such as gastric volvulus, small bowel obstruction, which is due to lesions in the terminal ileum, such as Crohn's disease. Metabolic causes such as pregnancy, diabetes mellitus, hypercalcemia, Addison's disease, and so on. It's important not to forget the central nervous system, problems such as migraine headaches, or lesions in the central nervous system that can raise intracranial pressure, such as neoplasms. Upper GI inflammatory conditions such as recurrent pancreatitis or biliary tract disease, certain medications such as narcotic analgesics, nonsteroidal anti-inflammatory drugs, or digitalis toxicity. As well, ethanol abuse, anorexia, and bulimia should also be considered.
What about cyclic vomiting syndrome?
Yes, that's a very good thought. This is a rare but frequently considered diagnosis with episodic vomiting. And this syndrome is more frequently seen in children, but is increasingly recognized in adults. The episodes of nausea and vomiting are almost identical in character, with predictable onset triggers and durations, and are usually separated by asymptomatic or nearly asymptomatic intervals. Often patients will have an associated transient visual loss, or aura, and some patients will have a headache after the vomiting has resolved. Often there's a personal or family history of migraine headaches. And it's important to recognize this clinical syndrome, as many patients will respond to anti-migraine drugs such as sumatriptan. I would say that the lack of migraine headaches and other auras makes the cyclic vomiting syndrome less likely in this case. What are your thoughts about this diagnosis, Adriana?
Well, for me, when I heard the clinical history of intermittent episodes of nausea and vomiting with complete absence of symptoms in between episodes, combined with this unusual story of compulsive bathing behavior where the patient would lay in the tub for hours at a time to the point where he had a scalding rash on his flanks, I was reminded of several cases that I have seen before related to chronic consumption of marijuana. So my next question to this young man would be about his marijuana usage.
Okay, so you're thinking about the cannabis hyperemesis syndrome. And as you know, this is an increasingly recognized cause of episodic nausea and vomiting, particularly vomiting severe enough to require emergency department assessment. This syndrome was initially described in Holland, and the initial description was of 9 patients with cyclical hyperemesis in the setting of chronic cannabis use. Most of these patients had some form of compulsive bathing behavior, spending significant amounts of time in the bathtub or the shower in an attempt to obtain relief. Most experienced resolution of the symptoms with cessation of cannabis use. 3 of the patients actually re-challenged themselves with marijuana, and their symptoms promptly recurred. Well, it turns out that our patient today had actually been smoking marijuana 3 to 4 joints a day for several years. It is unclear how marijuana actually produces this syndrome in chronic users. It may be due to the accumulation of a toxic metabolite of THC, or it may be due to a contaminant on the marijuana leaf itself as a consequence of the growing process. I asked the patient to stop smoking marijuana, which he did, and on a follow-up clinical visit 2 months later, the patient has actually remained symptom-free.
What do you think are the learning points for today?
In reflecting back on this case, I think the key to the diagnosis was the recognition that this patient had chronic episodic nausea and vomiting. Working through the differential diagnosis in my head led me to consider toxic causes such as the cannabis hyperemesis syndrome. I would like to emphasize that it's important to keep in your mind the 4 different clinical presentations of nausea and vomiting discussed earlier, and having a brief differential diagnosis readily at hand for each of these scenarios will aid you immensely in dealing with this common clinical problem.
Well, that concludes this week's episode. Stay tuned next week to GI 101 as we discuss common clinical problems arising from the GI tract. Bye for now.